Today we have Dr. Hesam talking about how do we allocate resources under conditions of scarcity. Hesam is an assistant professor in the Centre for Healthcare and Communities at Coventry University. His research interests encompass the economic evaluation of health medical services, with particular focus on mental health. So at the end of the session today, we'll have time for Q&A. So please post your questions throughout in the Q&A function. If you want to ask your question in person at the end, use the raise hand function and we can unmute you so you can ask your question in person. As you'll see, this session will be recorded and uploaded on our YouTube channel, and I'll share this link with you sometime this week as well. So Hesam, over to you.
Thank you so much, and thanks for having me, and hello everybody, nice to meet you all here. So the outline of what I'm going to talk about today is as here. So first of all, why resource allocation is important for any health system, not just industrial and high income countries. It's a problem over the world. So, and then we are going to have some digging out from what's going on in the context of the UK, especially in terms of the healthcare expenditure, because health funding is the main important resource and the main concern for every single health system around the world. And then going to the hard inverse care law and what's the inverse care law saying about the UK current situation. Then the drivers of stretched healthcare expenditures, especially after COVID-19, and then the definition for healthcare resource allocation. Sometimes it's exchangeable wording between resource allocation, rationing, priority setting, and economic evaluation and decision making as well. Then we are going to speak about efficiency and equality as the two main criteria for resource allocation and the two main concerns in any health settings for allocating the resource. So, and then approach to healthcare resource allocation, then what would be the pure cost effectiveness analysis and what would be the better and broadened view of resource allocation through the MDCA or multiple decision-making criteria, and the current initiative that which has been implemented by UK government, especially the integrated care systems and health determinant research collaboration, and what would be their contributions to the current health care resource allocation. At the end of the day, we've got some conclusions for you, and you are free and welcome for any QA as Jack mentioned. So the problem here is why resource allocation and why it should be the matter of interest. We know that no health system around the world can meet all health needs, and there are lots of health needs. And in addition, health sector in itself is a part of a broadened public sectors that is competing with other sectors to have a fund or any other resources. In addition, within health system, we know that there are lots of services, technologies, medicines, programs, etc., that they need to be funded, and they need to have enough and equitable share of money and other resources such as human resources to be able to meet the population's health needs. So there is an imbalance scales between what is often allocated to healthcare systems and what they actually need. And this is an open end about what would be the best criteria and option for any healthcare system. So as a matter of context, in the UK current situation, you can see in these graphs here what expenditure and spending has been occurred for healthcare system within the UK. You can see over 185 billion pounds within the last few years just has been allocated to healthcare system, mainly for NHS, and it's a huge amount, but still there are lots of unmet health needs, especially within the lower socioeconomic population and subgroup population indeed. So, and then you can see here the current growth in funding falls below the long-term historical average by government. For example, the most growth for healthcare expenditure in the UK just is related to 1997 to 2010, which is under the Labour governments by Blair and Brown, and then 2019 to 2023 for Johnson, Truss, and Sunak Conservative. However, when we are looking at the long-term average, just pre-COVID-19 outbreak here, the expenditure and the figures here is not including, anything about the COVID situation, because it just caused a bit more stretch on the healthcare expenditure in the UK. You can see it's 3.9% growth in the healthcare expenditure. And there is something uh, uh, problematic about the healthcare resources in the UK that we called it Hearts Inwards Care Law. So the law this law says that by moving from advantage socioeconomic groups to disadvantaged socioeconomic groups, while the clinical need and any other medical need would be increasing, but the provided resources would be decreasing, and it would be a gap between more affluent socioeconomic groups rather than the less affluent socioeconomic group. So it means that this gap should be considered, and there are lots of try in behind of the scene to address this problem. So based on a report from Health Foundation, it appears that the GP practice appointments for population over the time between 2015 to 2018, it's a shortage and a gap of 7% of funding for patients who are less advantaged in terms of their socioeconomic status. So what's the drivers of this stretch healthcare expenditure? So it could be outlined as below, but there should be lots of other factors, but mainly it could be related to demographic pressure. So we know that the growing rate of population and aging population especially. So there are some evidence that show that as the population gets aged, the number of the health needs for them and the cost associated with those health needs would be increasing as well. The other thing is in terms of the increasing prevalence of chronic health situation and condition and illness, such as higher blood pressure and diabetes and obesity as well. And then the change in public expectation and preference. People in nowadays have more expectations from their healthcare systems. They can't wait for, long waiting list, and they just want more, and they are more concerned about their health rather than they are maybe less careful about their health at some point, especially for those factors of healthcare that related to their lifestyle, such as physical exercise, alcohol, smoking, and any other things. The last drivers could be technological and medicinal advancements, especially the diagnostic and detective technology. They are not cheap and they are usually at very high cost. So then, what would be the healthcare resource allocation in such a context? We know that there are scarcity and there is a limited resources available for any healthcare system, especially when it comes to publicly funded system. So in this imbalance situation, resource allocation playing a very vital role. You can see in this picture that, for example, the Chancellor of Exchequer here with his red box just being, confused and just would be suffering from a headache when it comes to allocating the resource to different and a variety of healthcare needs and demands between different group of population. So there are usually two main criteria for allocating the resource in healthcare system. The first one called efficiency and the second one called equity. So about the first one, general efficiency refers to the best source in a way utilizing the best source, the best of the source in a way that make it valuable for paid money. It derived from a concept that we called it opportunity cost. Opportunity cost means that the value or the best foregone alternative when a decision made. For example, imagine that currently you are sitting in this webinar, right? And then you've already foregone the time, the value of the time that you could spend to an activity or work that might give you a better return. So I'm really hopeful that you are not on that way and you are not being like that. So and the other thing might be a more, clear idea about opportunity cost. Imagine that I'm working for the university as an assistant professor with a payment, an annual salary of some few pounds for a year. But if I just had the opportunity to work in industry and for a private sector, I could make more money. So that would be the opportunity cost for me or for anybody else around. Usually, efficiency could be categorized as technical efficiency and allocative efficiency. The technical efficiency refers to the maximum possible improvements in outcome is obtained from a set of resource inputs, which means that we can get the best and the most from the current available inputs demanding with no demand for more resource inputs. The allocative efficiency means resources are allocated between health programs in such a way that maximizes health. So we know that there are lots of care, dental care, for example. So cancer, the drug, and for example, for CVD, cardiovascular disease, we've got lots of programs, we've got lots of medicine and technology. So allocative efficiency define which one of these could be prioritized against the other one, and the resource should go for that. And about the equity could be defined based on the outcome and based on the matter of interest that we are defining. Sometimes the equity could be defined based on the health outcomes. For example, the blood pressure, for example, the obesity rate, the obesity prevalence, I mean. So, and the quality of life and the severity of disease. Sometimes it could be defined as equity in the healthcare service availability and accessibility. To what extent a healthcare system is able to make the resources available and accessible. And healthcare utilization, to what extent the people who are targeted could afford the healthcare systems and could utilize their healthcare system that they need. And at the end, the healthcare expenditure as well. So healthcare systems should make equitable opportunity to healthcare users. This is what they can do. However, for some of these aspects of equity, for example, for health outcomes, there are some other sectors that should be in place and should be in the program alongside the healthcare system, such as, for example, if we have some program for improving the health outcomes within the population, we need to have a social determinant health approach, which means that there is beyond merely from the healthcare system responsibilities, and other sectors should have their role. And in the other way, there is some other definition for health equity. Sometimes we say that people with the same needs need to get same care and services, which is this horizontal equity. Sometimes we say that people should contribute to the payment based on their capacity or ability to pay. And this is something that we call it vertical equity. Anyway, whatever we call equity in health, it should be met and it should be considered in any healthcare resource allocation. But sometimes there is a dilemma between efficiency and equity, and there is some conflicts between them. For example, imagine that we've got a NHS policy on cervical cancer screening, and it aims to maximize coverage through economic incentives for general practitioners. However, there are low participation rates among people who are in the lower socioeconomic groups. Or the other thing is related to a rare disease that we called it sickle cell disease. This is a rare disease that is more common and prevalent among people who are from minority and ethnicities such as Black people and Caribbean people. So it's very important for NHS to make sure that those people have not been deprived from the right of access to their needed health. Uh, there are different approach for healthcare resources allocation. So we can even add some more to this list of 9. For example, some of them should be need-based allocation. Sometimes it is based on an egalitarian approach, which is more concerning about equity and equality, and utilitarian, which is main concern about the efficiency, and they are more emphasizing on cost effectiveness analysis and budget impact analysis, and something that is more quantitative in terms of allocating the research. Sometimes we've got some approach in terms of priority to the worst of, or market-based. Market-based is more common in countries such as US, where there are lots of health insurance provider, but in a private sector or in a private market, so they are not under the national or governmental authorities. So, and it makes it very difficult to meet the health care needs for many, for population over there. The other one is merit-based. This should be not very equitable one, because merit-based said we are providing the service to people who are contributing to the economy and they are actively in the market. So then what happened for people who have no any chance to be a part of the market and making money? Sometimes it could be random, which means that we have no plan and idea in terms of who will be utilizing from this allocated resource. This is one of the worst one scenario. And sometimes it's based on incrementalism. And at the end, it's some considerations. So ethical and cultural considerations, namely. So the main tree approach among all of those 9, the main tree approach for allocating the resource could be summarized within this need-based, egalitarian, and utilitarian. So the need-based say that prioritize resources for individual or population with the greatest need. So the element of decision here and the criteria that they make their decision to allocating the resource are severity of illness, which means that we are going to allocate the resource to those with the most severe condition, and the urgency, prioritizing the cases that require immediate attention, and social determinant of health, which means that we are looking at something and some factors like socioeconomic status, geographic location, and sometimes people who are hard to reach, people who are marginalized. And these are some factors when we are approaching the need-based model for allocating our resource. Sometimes we are going to have an egalitarian approach, which means that we need to guarantee an equal access to healthcare resources for everyone, regardless of their current situation in terms of the socioeconomic status, their ethnicities, their income, or etc. So this has 2 elements for decision. The first one is the equal distribution, which means that the same level of access to health care services for all. As I mentioned, this could be referred as horizontal equity as well, which means that people with the same need should be considered at the same behavior and at the same level of services. And sometimes we've got uniform standards, the same criteria for treatment and resources distribution, regardless of individual differences. So the third important approach for allocating the resource is utilitarian, which means that we are going to maximize overall health benefits, often using cost effectiveness analysis. It's just all about quantifying the money and all about assessing the value for the money for health care and technologies that we are going to cover. And the main criteria that they are using here is maximizing the outcome, which means that we are going to allocating resources to intervention that provide the greatest health benefit to the largest number of people. So here is dangerous for people who might be in minority and who might have, for example, a rare disease condition or a rare or they are not a part of the largest number of people. So the equity here should be a victim of maximizing the outcome, and it should be completed by some other equity aspects and equity oriented criteria, which I'll be referring to it later on. So, and the cost effectiveness. The other criteria here is cost effectiveness, which means that we are going to prioritize treatment that offer the most significant health improvements per unit of cost. What we gained from each per unit cost in terms of the quality of life, because quality of life is usually the general metric that is used in any cost effectiveness analysis. Alongside the cost effectiveness analysis, sometimes they will use something that's called budget impact analysis, which means that what would be the cost impact of covering a new treatment or a new technologies for treating or managing health illness. So, but it should be noted that no countries around the world would not be using just one single approach for resource allocation. It just depends, and it's just something that we need to consider and take into account based on the situation. For example, many healthcare systems around the world use a combination of those. Imagine that we've got a triage in emergency situation. A triage is usually a combining between the need-based, because we are prioritize people with the urgent situation over the other people, and at the same time we are looking at the best possible value for money in terms of the treatments and care we are offering to them. Here in the UK, NHS usually use a combination of egalitarian, utilitarian, and need-based principle. So, for example, for patient with rare disease, for making sure that they have not been deprived from their right to access to health care, we usually use the egalitarian approach. But for many of other diseases and situations, the NHS which prefer to use the utilitarian based on cost effectiveness analysis and budget impact analysis. And that's why my field, I mean, health economics, is very important in this country. I can't see any other country that's give that high level of priority to health economics rather than UK. Maybe it's very generous in terms of allocating financial resource here in this country. I mean the public authority, but it's a lucky, it's a good point at least for people like me with health economics background. So we have insurance-based systems as well. It's very common in the UK, but it's different from what we know in European country because it's based on market and reflecting the market and a competition between different insurance systems. Sometimes they are offering different policies, which means that patients and insured people need to pay different level of premium and co-payments, and the reimbursements would be different. And people could utilize those insurance-based systems based on their contribution to the economy, which means that it's a merit-based, which means that if a person has no job, there is no chance for him to have an insurance-based system. However, we know that there are some reforms in the US as well, such as Obamacare, which targets people who are poor or who are not available in the market and active in the market. So the other thing that we might consider here is cost effectiveness analysis and changing and shifting from it to a new year concept that we called it multiple decision-making criteria, or MDCA. We know that the cost effectiveness analysis, as I mentioned, is merely use the value for money for and budget impact analysis as well to make a decision about having or not having a care within our current NHS commitment. And it's mostly employed in this country for many of services. However, this approach sometimes have some lacks in terms of considering the equity, and it's a risk to have some people behind the door of NHS, especially people who are, are in the minority or care who are rare, such as sickle blood cell. So, and for such a situation, there are two solutions at the moment which are developing. Maybe they are at very initial steps and need times to be more developed. The first one is distributional cost effectiveness analysis. So the distributional cost effectiveness analysis says that alongside the efficiency and the opportunity cost, we might consider the socioeconomic status of people and any other demographical background of people and disease category to decide about having or not having services or care in our current health situation, in a health system. And alongside this, we've got multiple decision criteria, which means that a systematic and theory-based approach to perform a comparative analysis of several competing options. Sometimes these options is a competing. There are a list of options within the MDCA, and each of them enjoys predefined weights for making the decision making easier and life easier for decision maker. Such as criteria could be listed as, for example, the clinical effectiveness, so the cost and economic impact, equity and fairness, feasibility and implementability, patient-centered factors, and etc. So each of these factors may be enjoying a specific weight, and at the end of the day, based on the sum of those weights, it should be a decision to have or not having care or services within our health system. But sometimes, as you can see here, some of those aspects could be conflicting to each other, against each other. For example, cost and economic impact, especially in terms of cost effectiveness against the equity and fairness. So it's very tough methods to be used, and currently in the UK it's not very prevalent to be used. So in response to such situation and in response to the problem that we are facing at the moment, some initiatives have been implemented and developed by UK government. So we know that the integrated care systems are a part of those initiatives, which will be helping the healthcare system to allocate the resource based on the local need and decentralize the decision making from the central part of the government and from the higher level of governmental authority to the lower level and the local and sometimes peripheral local authorities. So the aim of the initiative itself is improving outcome in population health and healthcare, and tackling inequalities in outcomes, and enhancing productivity and value for money, and helping the NHS to support broader social and economic development. So we know that, for example, the ICS are at the very beginning and early steps of their development. There should be lots of problems with them at the moment, and lots of, some mess around in terms of their duties and the way that they are doing the work. However, it seems that decentralizing decision making for allocating the healthcare resource would be something that required in future. And in the future healthcare systems, we need to be a bit more agile with just delegating some sort of authorities to the local government as well, especially when it comes to resource allocation. So the other things that is the HDRCs as well. Also, HDRCs are mainly related to research. However, it could be very helpful in terms of making evidence and synthesizing the evidence that would help policymakers either at local and peripheral levels or at governmental and central and national levels to make a better decision in terms of equity-oriented resource allocation pattern. So these two initiatives would be very helpful in terms of their functionality and their roles to help policymakers in allocating the resources. So as a conclusion and some points for this presentation, I would like to end up with these briefs and saying that, so we know that resources are limited and it's very clear and obvious and needs unlimited. Equity and efficiency are commonly used to allocating the resources in health system. However, in the background of what I'm saying here, for example, in terms of equity or efficiency, there are lots of methodological, technical issues and developments that they are employed by researchers or any other people who are interested in such topics to make evidence for healthcare decision maker or policy makers. So the three common approach for allocating the research in healthcare system are need-based resource allocation alongside egalitarian and utilitarian, and also a combination of them usually are used. We know that cost effectiveness analysis and budget impact analysis are mainly focusing on allocating the resources efficiently in a utilitarian approach, but they are not enough for some situations, especially when it comes to equity-oriented policy making and allocating the resources. So lots of other factors alongside this should be considered. And it's very interesting for me, for example, many of decisions within the healthcare system, even here in the UK, are not made based on purely the cost effectiveness analysis or budget impact analysis results, which means that there are lots of other factors in background, such as public pressure, such as equity-oriented concerns, such as population needs. All of them are a package that should be considered and are considered in the current practice for policy making around the resource allocation for healthcare systems. So cost effectiveness analysis are limited because they are not having explicit criteria for equity considerations, so that there are some approach and some shift from traditional or conventional cost effectiveness analysis and budget impact analysis to distributional cost effectiveness analysis and multiple decision making criteria approach. And these two are looking at something beyond the current cost effectiveness analysis and might be useful for policymakers to know about them and when it comes to allocating the resource. So it was me, and thank you for your attention. So it's all over to you, or any questions that you've got. Hopefully I can answer some of them. Okay.
Perfect. Thanks, Hesam. If you want to stop sharing, then we can go on big. So there's a couple of questions in the chat already. So one relates to one of your early slides around the changes in healthcare funding. So people are keen to know whether that funding includes funding for public health services routed via local authorities.
It could, because I just took them from health foundations, and it includes just the general funding for healthcare system here in the UK by different, sorry, just let me share it, then I can go through it. So this one, I think it should be this one. So yeah, it could be, because here we know that, for example, this is the Department of Health and Social Care total budget, and the budget that has been allocated to NHS, because NHS mainly absorb the research. And then this is based on the Health Foundation report, but yeah, it could be any other, more and less, a different, I mean, figures around this. Yeah.
Great, thank you. And then I had a question around, so a lot of these concepts we're really familiar with in
Mm.
healthcare, but
Yeah.
obviously with the health determinants, we go much beyond healthcare, as you can see, all down that side, things like transport, housing, air quality, all those kind of things. How could people who are working in those fields go about applying some of the concepts that you've just discussed today into their
Mm.
area and things like finding evidence and those kind of things?
Oh, well, so for example, there are lots of concerns in terms of the equity-oriented healthcare resource allocations. And we know that in the current situation, it's mainly based on the efficiency or efficient criteria for finding some efficient criteria for approving the value for the money. So it could be something, for example, around how the other factors could be integrated within the current policymaking practice in the UK, either at local, level, or central or national level. It's very important for policymakers to know something, tangible, something that makes sense for them, because they need to know some evidence that is quantified, and they are more, interested in something that it's tangible, sensible for them, and you can translate them to some part of their current and routine policymakers. So we know that, for example, social determinant of health is a very wide and broad approach, not only focusing on the health systems itself, but also focusing on the other sectors and other aspects of health players. So, uh, you know, it's very important, especially when we are working at the Health Determinant Research Center, to make some ways in terms of how we could apply evidence from equity and equality-based research to the current UK practice for allocating the resource. Imagine that uh, the projects that are conducted or supported by Foundation, for example. There are lots of examples over there and lots of projects that they are working at the moment, mainly focusing on, factors rather than efficiency, and how to translate them, translate and transport them to policymakers as well. So I think, yeah, there are lots of, unmet demand for healthcare research and research allocation within the current health determinant of research centers or something similar to that.
Great, thank you.
Uh-huh.
So we have a question from somebody working in the street lighting team,
Mm.
actually in Coventry City Council. So as everyone's fully aware, local authorities are under kind of financial constraints and stuff. So they asked a question. So they've been contacted by vulnerable residents about the street lighting being switched off overnight, save money, save
Mm.
energy. So they've been contacted by vulnerable residents that have been adversely impacted by this, and I'd like some kind of terminology they could use to respond to those residents. I guess in explaining that decision and its impact. Is that something you
Well,
could advise and suggest on?
so for people, sorry, I just missed the.
Yeah, so
Who
vulnerable
are the
residents
people?
have been in contact about the street lighting being switched off. So the council, someone from the council would like to know about what kind of terminology they could use to explain why that's been done.
So it's just, so here it seems that, so if I just want to say something, because this is something beyond the current healthcare system, I think it's something that,
Yeah.
so it's a part of determinant of health. I don't know what would be the implications for this when it comes to health itself. So, and sorry, I have no any clear idea about that. That's something new for myself as well. But yeah, I can maybe later on think about this, because yeah, it's something beyond the current situation. And
Yeah. Yeah, no
yeah,
worries.
yeah.
And if anything comes to mind, I can always forward on your thoughts
Mhm.
to Carl. So a couple of other questions. So we've got one about how the MDCA in local authorities, do you have any examples of that being applied in local authorities, both within and across departments?
Yeah. So the problem here with the MDCA is to finding a scale for those different and sometimes conflicting factors within an MDCA. So for example, imagine that we are looking at the severity of illness. At the same time, we are looking at how it could be efficient and cost effective. And the other thing is how it has been, distributed between different population. So, but here, in terms of the methodological and applicability of it, it's mainly based on consensus and a deliberative process. You need to find people at different so from different stakeholders, gathering and putting all of them together, finding out through a study what would be the best weight or what would be the best score for each of these single criteria in the context of the problem that you are seeking for. And then, it's something that needs a multiple stakeholder and multiple round of sessions with the stakeholders, identifying those stakeholders, then having the, some agreements with them in terms of what would be the best criteria to be included for the specific and the context that they are looking at and how they are going to valuing them. And at the end, what would be the product of that. So this is not something that, for example, I can lonely think about and think around it. It's inter or multidisciplinary team working efforts, and you need to gather all of those together. So I'm not aware of the German models. However, it should be something in background, and it should be something as a manual or guide to be used here as well. Why not? Sometimes in health economics and policy making, we are going for benchmarking, and we are going to have literature review, systematic literature review, to find out the practice that they are using, and we just adjust it and localize it based on the current situation and context in UK, or even in a specific region in the UK.
Great, thank you.
You're welcome.
We're in the last minute, so one last question, and apologies to anyone we've not been able to ask your questions. Feel free to get in touch with us, and we can always provide some more information afterwards. Someone asked about how are the weighting values in the MDCA decided? Does that depend on prior values, whether explicit or implicit?
Oh, no, it's not necessarily, based on a very well-defined criteria. This is based on people's inputs, and sometimes based on what we can extract from literature. But when it comes to people judgments, it's something that I can say mainly based on the view and the judgments of the people that are. For example, I'm health economics, and for me, cost effectiveness analysis is very important. So if I
Yeah,
just sit at that meeting, I say, oh, okay, I'm just going to give a bigger weight to economic evaluation part. But somebody else from a different background, and he say that, oh, okay, I'm an equity oriented person, and I'm a social activist. So
yeah,
he's or she's going to give a greater weight. But it's just a consensus, and it's just a process of discussion and tailored discussion to reach a point that all people have some agreements on. At least they are at the same ballpark. if they can't reach to an exact point of agreement. So this is the waiting process for that. But it's very interesting one, and I think it could be used especially when you are looking at your local authorities meetings to allocate the resource.
Yeah, great. Well,
That's it.
thank you very much for that, Hesam, and thank
You're
you for
welcome.
your questions.
It's my pleasure.
The last link I've just posted in the chat is the timetable of our future webinars, and I'll share the link to the recording of this session later on today or this week once it's available. So yeah, thank you everyone.
That's great. Thank you for having me. Cheers.